Okay, Madam Chair.
Thank you, Mary. All right, let's call this meeting to order. Welcome to the Grey Bruce Board of Health meeting for Friday, April 22nd, 2022. Happy Earth Day to everyone. Mary, please start the roll call.
Sue Patterson.
Present.
Alan Barfoot.
Present.
Brian Mill.
Present.
Brian O'Leary.
Present.
Chris Peabody, Luke Charbonneau, and Selwyn Hicks send their regrets. Helen Claire Tingley.
Good morning, Mary.
Janice Jackson.
I'm here.
Nick Saunders.
Okay,
Nick Saunders.
he may join us when he's available. Thank you, Mary. So we do have quorum. 5 is quorum, so we're good to go. Are there any amendments to the agenda? Seeing none, I'll ask for a motion to approve the agenda as presented. Alan and Brian Millen, all in favor? That's carried. Thank you. Does anyone have a disclosure of pecuniary interest or a conflict of interest? Seeing none, if one should arise during the meeting, you may declare it then. Item 5 is our educational notes. And again, this is just a brief continuous learning that will benefit all of us. And Mary, you're going to put up the roles and responsibilities. I'm just going to highlight the governance and management roles and responsibilities. And there's 6 items, but we're only going to do 3 today and 3 at the next meeting. So good. Thank you, Dr. Era. So the board's role for the vision is to continuously review, explore, and refine the organization's vision, and it requires highly participative processes for shared vision, strategy development, and feedback. The CEO's role is a shared vision to ensure teams and staff throughout the organization have ownership of the evolving vision and strategy. It is also to lead and manage transformation, the process. The second one is for the board's role is to approve the strategic directions, which includes long-term strategy and targets and partnerships and system integration. The CEO's role for strategic directions is to define and communicate. And that includes identifying financial and non-financial drivers, capacity building for a balanced scorecard, the input through a cascading process, and partnership and system integration. The board's role for overseeing financial activities includes performance review, monitoring the process, fiscal policy, strategic budgeting, ensuring leveraged use of resources, and approving major capital expenditures. The CEO's role is to manage the financial resources, and that is fiscal policy and strategic budgeting, forecasting and strategic budgeting, propose major capital expenditures, and to balance the budget. So that's just a little brief learning session. Does anyone have any questions or comments? Just sort of defines the roles of what we do as a board and what the CEO does. Janice?
Thank you, Madam Chair. I'm wondering how long has this been in place and who wrote this?
Dr. Era, this is in our orientation package.
Thank you, Madam Chair. Through you, this has been in the orientation package for the board. I believe it was before I joined the health unit. It is chapter number 8 in the orientation package. I don't know how many years before I joined it was there, but I believe Dr. Lynn had it in the orientation package for years.
So you wouldn't have any idea then who wrote it, I would imagine. Do you know if this is comparable to other boards in Ontario? I've never seen, this is the first time I've ever been on a Board of Health, so
Through you, Madam Chair, this is best practice for over 20, 30 years about the role of corporation and the board of corporation and the CEO. And this related to the balance scored card. I can share another screen, which really relates to this subject. It's this is a study by a group of financial leaders or executive leaders and boards, and it is published. Sorry, I was just trying to find the publication of it. Deep change discovering leadership within. So it was published in 2003. Much of this information correlate with the document itself when we were looking at updating the board package, orientation package that was circulated to all board members early in the year. I looked at recent literature specifically about balanced scorecard. That's the same mechanism Dr. Zaid is using in the matrix organization and in the strategic planning and measuring the progress. And it is very relevant to that document. I don't know the source of the actual document, but we can definitely look into the archives. I'll ask the executive assistant to look into the references of that document.
No, that would be great. No, I'm asking because, like, as municipal representatives, we're governed by the Municipal Act. So I was just curious. So thank you for that.
Okay, any other comments or questions? Helen Claire?
Thank you, Madam Chair. I just wanted to observe that this is consistent with the training that myself and the other provincial appointee received with regard to the enabling legislation and the fact that the health board is a strategic board rather than an operational board. So it's high level board governance. So that was just what I wanted to observe. This is absolutely consistent with the training that we received as provincial appointees. Thank you, Madam Chair.
Okay, very good. All right, so we'll move on. Item 6 is adoption of the minutes. And these minutes are our regular board meeting minutes from March 25th. And you'll remember that's when we had the presentation from Jillian Jordan. She spoke about the infection disease program and presented on case and contact management, outbreak management, and supportive congregate settings. We also had an update from Dr. Era regarding the COVID-19 emergency and the emergency timeline. And Dr. Zayed provided a summary on the work of the health unit addressing the opioid situation and mental health in Grey Bruce. So if there is any questions or discussion, I'll be open to that. If not, I'll take a mover and seconder to approve those minutes. Brian O'Leary and Janice Jackson. All in favor? That is carried. Thank you. Item 7 is the correspondence package 7.1, and we have Denise or Dr. Era to highlight the correspondence.
Thank you, Madam Chair. We have 4 correspondence items for this month. The first one is from Windsor, Essex County Health Unit, and it is a letter of support to the Ontario regulations, specifically that supported public health and other organizations in its response to the emergency and the relationship with the unions in a way that unions would allow certain functions to happen during the emergency. I believe this regulation has been useful during the emergency. Coming out of the emergency, for Grey Bruce, it might not be as relevant. We have been in recovery for a couple months now, and the pace of the work definitely slowed down or accelerated on the recovery front, but the recovery front is not as urgent in a way that we can align our tasks without the need to take drastic measures. And the second reason my recommendation would be to receive this item is the fact that we have optimal relationship with our unions, and during the emergency, I would say they have been supportive in ensuring that the business of the health unit, which is the safety of the public, continues without any barriers or restrictions. It has been optimal relationship there. So this regulation, although might be useful for other parts of the province, for us at this point, my recommendation is to receive. The three other items are related to the letter that was sent from Sudbury Health Unit, and we had a discussion in March at our board where we identified this letter could be addressing things that could be political, not specifically related to health or bordering that. So our recommendation, or the board decided at the time to receive, and my recommendation is also to receive at this point.
Thank you, Dr. Era. Any comments about the correspondence? All right, we'll move on. 7.2 is news releases. Welcome, Denis.
Thank you, and through you, Madam Chair. There are 9 news releases on today's agenda. 3 relate to COVID-19. 1 informs residents that eligibility has expanded for 4th doses to include individuals 60 and over and First Nation, Inuit, Métis individuals and their non-Indigenous household members age 18 and over. An interval of 5 months between the 3rd and 4th dose is recommended, meaning the number of Grey Bruce residents eligible for a 4th dose on any given day will fluctuate based on when their last vaccine was administered. Another news release announces that the health unit had received a limited shipment of the protein-based Novavax vaccine, which offers an option for individuals unwilling or unable to receive an mRNA COVID-19 vaccine. Public Health is also holding 4 community COVID-19 vaccine clinics in April to support residents in getting up to date on their vaccines. And there are also news releases on the 2022 health unit budget, public sector salary disclosure list, oral health month, and the free well water testing program, as well as on influenza A's arrival in Grey Bruce and confirmation of avian influenza in a local poultry stock. Happy to take any questions.
Thank you, Denis. Any comments or questions for the news releases? Brian Millen and then Brian O'Leary.
Thank you, Madam Chair. The question is probably directed to Dr. Era, but I'm wondering, does the health unit or is it CFIA that takes the lead on the avian flu issue, or some other agency?
Through you, Madam Chair, it is the federal level that takes the lead on the avian flu influenza in farms or in birds or in humans. The health unit becomes the lead if CFA did not take the lead, if they did not complete the job, or if they, I'm using probably the lay language there. If the protocols is the federal level will be taking the lead. If not, if they did not for some reason, it will be the health unit. And in this case, we are supporting there.
Thank you.
Okay. Brian O'Leary.
Thanks, Madam Chair. A question for Denis. You mentioned that there's releases on the federal budget that just came out. Is there anything there on the public health system with the dental program or the expansion of the public health system, or is that premature?
Apologies, it was a news release on the Grey Bruce Health Unit budget. So that was at the very end of last month.
Okay, so Dr. we don't have any details on that then from the federal budget on expanding the dental program through public health?
We don't have the details at this point, through you, Madam Chair, and it could be a minor change or it could be drastic change. We don't have any details on it.
Okay, well, I just read about it this morning. I wasn't sure if you had details, but I'm wondering if you could just report on that next month. I'm just curious to see if it was significant or not. Thanks.
Certainly.
Okay. All right. I don't see any other hands, so I will, oh, Dr. Era?
Sorry, Madam Chair, just two comments there. Just to add to my previous answer, whenever we're involved in any investigation on the indigenous land, indigenous community, we do that through the approval of the chief and council and with their permission. And our goal is to support their community health center to do the job instead of us doing the job. And the reason for that is we want to build capacity in a way in the future they would be able to be completely independent in managing those investigations. That's one comment. The second one is this list of media releases is the first time that non-COVID business overweighs the COVID business, which is good news on many fronts.
Right, a good sign. So, all right, can I get a mover and seconder to approve the correspondence and news releases as presented? Alan moves, Brian O'Leary second, all in favor? That's carried. Thank you. Thanks, Denise.
Thank you.
Item 8 is a staff presentation, and this is on vaccine preventable disease. So we have Katie to present that.
Good morning.
Hi, Katie. Welcome.
Thank you. My audio had cut out as I was joining, so I assume I'm okay to just jump right into the presentation?
Yes, and we can hear you.
Perfect. I will just share my screen here then. And moving on.
Okay, that's good.
So as I just mentioned, we're going to discuss our progress to date, talk a little bit about vaccine hesitancy, the work that the team is currently doing, and then our plans as we move forward into recovery. So this data is as of March 2022, and you can see that Grey Bruce has delivered over 35,000 doses of COVID vaccine at that time. So this number here would be reflective of all of our delivery channels. So that would be pharmacy and primary care, as well as what we as a health unit have delivered. Our coverage rates in Grey Bruce are listed here, and you can see them by age. So it shows our overall coverage rate as 84% of individuals 12 plus being fully vaccinated. And then this also indicates the number of individuals that have received a third dose or a booster dose. And that dose is exceptionally important because data shows that the protection with 2 doses lies around 20 to 30% versus that 70% protection that you receive having that third dose. We were also able to reach out and administer our third dose ahead of other health units, and that enabled us to provide that early protection. So 84% is slightly lower than the provincial average, but we believe that some of this can be attributed to a sense of safety that is felt here. People aren't quite as afraid. We've had fairly good outcomes with low death or serious illness rates. So since the community doesn't have that perspective that a larger city might have with seeing the really negative effects of the virus, it can create this sense of security that might lead individuals to feeling as though they don't need further protection. A little bit more on our coverage rates here by geography. It's also broken down by number of doses with age groups as well. The lighter colored areas on the map indicate our lowest coverage areas, whereas the darker the coloring, the better the coverage rate in those areas. And we have utilized this data to be able to direct our strategic efforts and increase the coverage rates by offering community clinics where we have noticed that we have lower coverage. The next few slides here are just some data that Public Health Ontario has compiled, and it's regarding our hospitalization, ICU stay, and death rates. So these would be from December 2021 to March 2022. And then on each slide is highlighted just the rates of numbers who are fully vaccinated with a booster versus not vaccinated at all. So this slide would be speaking to our hospital admission rates, and you can see the total number here with a series completion and boosters, 26 or 0.3% versus over 3,500 or 34.3% for those unvaccinated. This one would be showing that same data for our ICU admissions. And then these would be for the deaths related to COVID-19, 0.6% for those with completion of a series and a booster versus 35.5% in those that are unvaccinated. And this is just more local data as opposed to the Ontario data. And this is our hospitalizations in gray Bruce from February to March. So you can see vaccinated in hospital is 10 per 100,000 versus the 37 per 100,000 of unvaccinated. So despite this data and what we do know, vaccine hesitancy does still exist. And that's defined, of course, as a delay in acceptance or refusal of vaccine despite the availability. What we see with vaccine hesitant parents is typically they under immunize their children, falling in the middle of the spectrum there versus not immunizing at all. So this can be for a number of reasons that I have identified here, like complacency, convenience, so being able to conveniently access it, have time and priority, some confidence because of general fear, past experiences, or perceived risks or benefits, and then cultural reasons as well, such as religious beliefs and social context, distrust in the government or pharmaceutical industries. And ways that we have addressed that locally are with a number of marketing and communication interventions, town halls, radio, multiple communication channels. And then our comms team has also developed a video that includes comments from 2 local children, which was specifically targeted for those in that 5 to 11 age group in an effort to increase that uptake. So that was done, like I said, with 2 local children, one of our nurses here, and with the Canadian Mental Health Association's fan club puppets. I'm not going to play it here, just in the interest of time, but the link is available. Throughout our delivery, we have implemented another strategy to reduce barriers by offering a number of different modalities of delivery. And in a lot of cases, we continue to utilize many of these as well. So along with the traditional delivery channels of pharmacy and primary care, we also offered mass immunization clinics with the development of the Hockey Hub model, community clinics, large workplace clinics. So for places like Bruce Power, our military base, Chapman's, and the hospitals, just to name a few. We've also done school-based clinics. We have the homebound visiting program for those individuals that can't access care outside of their home. We did that in partnership with EMS. And then our mobile clinic team also provided vaccine all over Grey and Bruce to long-term care and retirement homes, congregate settings, foreign farm workers, and to the transient populations in many different housing facilities, shelters, and drop-in centers. So that brings us to our current COVID-19 vaccine work and our 4th dose plan. So we are currently still holding some community clinics for the rest of April. We have about 2 a week, still targeting those low coverage communities. We're working with the ministry and their GoVax program to host indoor community clinics throughout the month of May. You can see the dates listed there. And we will continue to support and promote our traditional methods of primary care and pharmacy delivery. So while we are Still working on our COVID-19 vaccine and our 4th dose rollout. We do want to ensure that that remains accessible. We are transitioning away from COVID-19 vaccine. So we will phase out our homebound delivery channel, and we'll support EMS as they take this on independently. To date, combined, we have been able to provide over 700 vaccines in homes for those who wouldn't be able to otherwise access it. And we'll continue to support primary care and hospitals with their onboarding, COVAX training, and vaccine supply. We continue to support the pharmacy partners by supplementing their vaccine allocations as well. And EMS also delivers through our SOS outreach, which is a combined effort. And we will provide community clinics based on the regional need and uptake. So as I've mentioned, we are doing them in April, and we'll continue throughout May. And we will use what we learned through the rest of April and May to determine the need moving forward into June and July with the 4th dose plan as eligibility becomes more increased. So as we move through recovery, we wanted to focus on a couple of priorities in BPD. So we want to use a creative and innovative approach to deliver informed programs and services. We want to meet ministry and locally identified immunization objectives with our ongoing catch-up plan. Leverage system transformation. So we want to leverage the lessons that we've learned during COVID and increase vaccine uptake. We want to increase awareness and address vaccine confidence issues. And then we want to support access to services and resources in all communities with our health equity approach, and tailor services to meet specific needs of each unique community. So these priorities and ideas to address each of them are in their infancy, so they do require further data collection, some collaboration with our foundational standards team, health equity, and then of course our senior leadership expertise to drive our desired outcomes. I'm going to address priorities 1 and 2 with engagement and awareness campaigns. Priority 3 for, again, utilizing our mass immunization model for delivery of routine IMS, and then address priority 4 and 5 through community partnerships. So for engagement and awareness, we're currently exploring different campaign ideas. So some of these ideas include a student teaching students campaign, where students from local schools can organize a campaign. Themes that they might cover could include why they should get routine vaccines, how they work, why they're important for short and long-term health, and which ones they should have received by the time they finish high school. This will help capitalize on publicly funded vaccines. And the goal of that project would be to just increase awareness and confidence amongst the youth, and then promote our catch-up plans that will have in place. So for system transformation, using what we've learned, we want to take parts of what we have learned with mass immunization and be able to implement them into our catch-up plan in the schools. So historically, it has taken months to get through our elementary school delivery with routine immunizations. So by combining what we've learned and using a larger common area with a really organized and strategic approach to address the whole cohort at once rather than individuals from the cohort at one time, we were able to accelerate that delivery schedule and get through all elementary school in 1 month versus a number of months. And then for community partnerships, this addresses our priorities 4 and 5 about knowledge brokering, health equity. We want to explore specific needs of our communities and work with community partners to assist in mobilizing initiatives that align with our goals and priorities as well. We'd like to further explore the opportunities to work with our Indigenous health clinics in our area and develop and deliver targeted awareness campaigns that explore creative ways to engage their communities in vaccine catch-up. And we will also explore ways in which routine vaccination rates with communities that do have lower uptake historically can be improved. So routine immunizations. Addressing the backlog of these past due routine immunizations is a top priority as we do look ahead into recovery. we were not able to be into the school. So the routine immunizations in the schools were behind by a couple of years. So we will work collaboratively with our school health team to effectively and efficiently communicate with our school boards and individual schools to be able to resume this delivery. In this Word document attached, there is a very detailed approach to addressing the backlog. It does include a number of other components of our VPD team work. So again, in the interest of time, I'm not sure that I should open it now. It speaks of all of the jobs, duties, and responsibilities, as well as our proposed timeline to catch up on everything. But again, it is available for you to take a deeper look at. I'll go over some of our main points again about the catch up in the next few slides here. So these indicate our total estimated number of backlog doses for our grades 7, 8s, 9s, and 10s. This would be their hepatitis B, HPV, and MenC. These are fairly accurate numbers of students that we'll need to immunize before the end of June in order to reach our goal of having the grade 7 and 8 students with their first dose of this 2-dose series, plus the mandatory MenC. And then grades 9 and 10s who had their series started prior to COVID to have them finished. So some of these numbers, this will be the most that we deliver, as some will be declined, although not many for the MenC, as that one is mandatory. So you can see the difference in the numbers here, especially for those grade 10s. So this amount of VPD work is really difficult to present clearly and be easily understood just because our target continues to move forward. It's really important that as we address the backlog, we need to also address those that are currently eligible in order to stay on track. So as I mentioned, our target is always moving forward. These new students are joining each school year. So I've added this table as well as another one to try and break down this information in a generalized way, just to demonstrate how we intend to reach our goal, which is that we will be completely caught up with our backlog and return to routine school delivery by the school year of 2023-2024. So you can see here, we're addressing our grade 10s, 9s, 8s, 7s. For these 10s, some may have only received a first dose. And these grade 9s, most of them did all receive their first dose in 2019, and then they were put on hold. So again, the idea here is that for the current 7s and 8s, they'll have their first dose by the end of this current school year. Grade 9s and 10s will be completely caught up by the end of this current school year. And then starting in the fall, they're currently in grade 6, but they'll be in grade 7, will be in to give their first dose as well as catch up in the current grade 7's second dose to be able to complete their series. And this one is a little bit nicer to look at. Just identifies what I've just said a little bit more clearly. So we hope to be returning to regular immunization with the backlog cleared by 2023, 2024, as I've mentioned. And then as we maintain our routine IMS as well as catch up on the backlog, some of our other recovery planning considerations are to end our community clinics. So we want to transition to traditional delivery models, primarily through primary care and pharmacy channels. We're working on our current state mapping and logic model. We want to do a full document review. So this would be our policies, procedures, guidance documents, best practice, review all of our medical directives. We want to focus on staff wellness. It's been a long couple of years. We want to resume our in-person collaboration, work on team building, and develop a lot of role clarity. And then again, just with the routine immunizations, get back on track with those and back on track with our data validation as well, which is just as behind as the school routine IMS were. And that brings us to the end here. So just to summarize, We've been exceptional. We've provided exceptional emergency response with our COVID-19 response and vaccine rollout. We are trying to transition away from the COVID-19 vaccine work while we meet the needs of the community and support this transition to traditional models with our 4th dose administration. We do have our recovery planning well underway. And while there are many considerations for recovery planning, the focus is at this time largely on our routine immunizations, just so that we can continue to work towards that strategic and aggressive timeline. I think we are one of the first health units to address this back in schools, and many of them are just in the planning stages now. So I think that's really wonderful that we are able to begin. At this time, we have already been in schools, and our elementary school delivery will be finished at the end of April, and we are in secondary school starting in May. And again, with the approach that I discussed earlier in the presentation, it's been able to really accelerate that delivery. So we are getting through every single elementary school in the month of April and every single secondary school in the month of May. Okay. That is all. I will stop sharing and then open it up to any questions. There's a good chance I might have spoken very quickly, so I'm sorry if I did.
That's okay. That was good, Katie. Thank you. Alan.
Thanks, Madam Chair. Great presentation, Katie. Nice and detailed. I guess I've got a clarification question. For those looking for the 4th dose, my understanding is if you go to book it on the provincial site, it says you have to be 5 months from your 3rd dose. But there's also pharmacies that are out advertising that as long as you've had 85 days, but after your 3rd dose, then you can get your 4th. So I guess I'm a little confused on what the message should be going out to people.
Messaging is 5 months. It's the 140 days. I'll maybe let Dr. Era elaborate. I don't know if he knows a little more than I do, but that is the messaging that we're pushing as well. The 84 days would refer to your first booster dose. Dr. Era, do you have anything to add to that?
Through you, Madam Chair, the recommendation from NACI is 6 months between the 2 doses. From the province, they made it shorter, 5 months. And the number you referenced is most likely related to after infection. After infection, a person needs to wait 3 months to get the 4th dose. So that correlates with the number you mentioned.
Okay.
Thank
Okay.
you.
Thank you.
Other questions, comments? I have Brian Millen, then Helen Clare.
Thank you, Madam Chair. In regards to vaccine hesitancy, is there any correlation between traditional or normal vaccines or vaccinations as opposed to the COVID-19? Like, is there the same level of hesitancy traditionally in the past as there seems to have been over the course of the COVID-19, or is it completely different?
I'll let Dr. Era speak to that.
Madam Chair, through you, before answering the question, I want to just use a different word than hesitancy. It's actually vaccine acceptance. Like we look in Ontario, the number of people who accepted the vaccine is way higher than what usual vaccines are. And on average, when we started the vaccine campaign, we're aiming for 70%, and that's around the number of people who would just accept the vaccine immediately. And we reached that in July. Then the Delta variant required more. And the more messaging there is about vaccine, the more messaging fatigue there is. So there is the perception that people are hesitant, and many people are hesitant. It's actually a very small sliver of the pie of the whole population. Specifically, the question, is there correlation? There is correlation between COVID vaccine and other vaccines as it relates to certain factors. The factors that decide vaccine hesitancy or acceptance is a wide array of reasons, and that was on one of the slides that Katie presented, whether it is personal reason, previous experience, religious, cultural, or sometimes a combination of which makes every single person almost a unique event. And it's a very complex area. So some of these variables are correlated throughout. For example, religious reasons, people would be hesitant for all vaccines, including the COVID vaccine. It's worth mentioning that Grey Bruce has always had above average provincial level of vaccination, and that predates me, and the credit goes to the team and the previous people who worked in the health unit and the current team, not myself. When I came in 2017, 18, we always had historically above average.
Thank you.
Helen Claire?
Yes, thank you, Madam Chair. Through you, first of all, kudos to Katie for a wonderful presentation. And I too am interested in looking at correlations between people who don't accept and other things. And in this case, it would seem to me that people that have primary care providers have the better opportunity to have their concerns addressed, whether they be cultural or religious or any of the other things that were on the list that Katie provided. I wondered if there had been any kind of data analysis between those that are not getting the vaccinations or not getting them on time, and whether there was a corollary between those people and those that don't have a primary care physician. Just again, thinking that the relationship between a patient and a primary care physician, if that relationship is there, it would seem that the confidence in the public health system may be better. And certainly there's a regular avenue with a trusted person in healthcare where the kinds of barriers could be potentially overcome, certainly discussed. So my question again is if there's been any sort of study looking at the correlation between those lacking primary care physicians in this area and those that are not accepting of the vaccine. Thank you, Madam Chair.
Dr. Era.
Through you, Madam Chair, there is overwhelming evidence in the literature that the most effective way of combating hesitancy, increased acceptance, is the connection between a primary care physician, healthcare provider, and the patient, without a doubt. And there are many applications to it, the last of which that we'll be writing actually a media release on the subject in the coming weeks. The Northern Peninsula, the family health team, the group, 8 physicians, I believe, have been very engaged in getting the vaccine out. By July 2020, they had over 93% acceptance rate in their roster group and their patient population. And the literature is very clear on it. It's the strongest evidence. The best intervention is to get primary care to call physician, to call a patient, sorry.
Helen Claire?
Thank you, Madam Chair. So just to follow up then, this perhaps might be an opportunity to try to address the systemic problem, meaning people that don't have primary care physicians, which is a long-standing issue. If we can, maybe if there's an opportunity to focus on that a little more in what I'm hoping is going to be a lull between major emergencies, the one that we're leaving now and the next one, which will surely be on the horizon. As Dr. Ara said, if this is the best way, which makes sense, maybe we can really put our heads together to do whatever we can to draw attention to this ongoing problem with the lack of primary physicians. Thank you, Madam Chair.
Okay. I have a question. Doctor, you want to respond to that, Dr. Aaron?
Yes, please, just to mention that it is definitely a cause that's worth pursuing. It's worth mentioning. It's not under a public health mandate, and it's not within our authority. Primary care and physicians are self-regulated through colleges. There is definitely a strong relationship with the Ministry of Funding. Ontario Health is probably the most suitable candidate to take the lead on that, which is the organization that is composed of many other organizations like the LIN and other healthcare system partners. Nevertheless, public health sits at the table with the Ontario Health Team in Grey Bruce, and we will do our best to increase recruiting physicians and retaining physicians.
Good. Helen Claire?
Thank you. Just to wrap up, I am aware of the differences, but because it does affect public health, because this uptake issue that we're looking at, I was thinking maybe if we could, leverage that. So thank you very much for that, Dr. Ara. If there's even anything that we can flag in terms of a formal letter stating that this, what everybody knows, but can be left behind. That's all I was trying to say. Thank you very much.
Okay, my question is, with students and catch up on the immunization, are they able to speed that up through another opportunity, like with a primary caregiver, or is it all done through the schools? Is that how it's documented? Katie?
No, it's not just done through the schools. You are right that they are able to receive them through their primary care provider. And some have already, which is why we needed to run the reports to have our accurate numbers. And they're also able to receive them in our community clinics. So we have 2 community clinics in Owen Sound and 1 in Walkerton each month. And there have been an increase in students catching up on their vaccines through that channel as well.
Good, that's good to hear. Thank you. Okay, any other comments or questions? I'll just say thank you very much, Katie. Oh, Dr. Ara?
Just thank you. I was going to echo exactly what you said. Thank you, Katie, and thank you, Dr. Zayed. I know Dr. Zayed is involved in every presentation that comes from operation, and her work and Katie's work is greatly appreciated.
Yes, the data is very good to see there. So thank you, Katie. Thank you, Dr. Zayed. All right, so moving on, item 9 is the Medical Officer of Health update. Dr. Ara.
Thank you, Madam Chair. My update is a positive update about the COVID progress. So there has been increase in circulation of the virus in the community that is very consistent with the lifting of restrictions. Nevertheless, there has not been increase in hospitalization. There is minimal number of COVID cases in ICU currently. There is increase in the perception of risk in general in the public, and there is discussion, for example, about the sewage water testing. It is important to point out that sewage water testing tests sewage water. And sometimes, and the past few weeks is one of these times where there is incongruency between the hospitalization and the ICU cases and the sewage water testing. And it's also on that subject, just because the public has been interested in it, sewage water testing is not appropriate for rural areas where septic system is quite common. So whatever happens in the municipal water system that can be tested in Owen Sound does not reflect anything in other parts of Grey Bruce where septic system is available. On the circulation of the virus, there is a high level of immunity in the community, whether it's the multiple vaccines or the natural immunity with wild virus. One of the studies from the UK's recently in the past 10 days, there is over 98% of the public had immunity, one form or other. Although it's a different jurisdiction, but there's many rates are comparable, whether related to the vaccine or infection. And we know the Omicron is less severe. So all these together, the danger of the pandemic is not about overwhelming the healthcare system at this point. Nevertheless, there is some danger. Some of it is related to school ability to operate, healthcare system related to absenteeism of workers, and the general workplace absenteeism rate. The reassuring aspect of all of those that there are public health measures in these organizations and through individuals themselves, whether it's wearing a mask or through management of human resources. For example, one of the large employers in Grey Bruce had an absenteeism rate of around 5%, quite manageable, where 5% will be sick, and in 5 days they will come back to the workplace. Another 5 will replace. The healthcare system chronically had low number of available human resources. So 5%, again, that was number of one of the absenteeism rate on one day in one of the hospitals. Did it affect services? It did. But was it detrimental to overwhelm the healthcare system? The past few weeks proven that it is quite manageable, and we have managers in these institutions that are quite capable in utilizing strategies to ensure absenteeism is not going to affect business or minimize its effect. The 2 meters distance remains one of the most important recommendations. Any person out and about, we're still in a pandemic, and if they're socializing outside of their household, 2 meters would be very helpful. Masking will be useful. The request or the public pressure requesting restrictions, in my assessment, and that is consistent with the provincial assessment as well, is not warranted at this point. Individual effort and organizational effort to utilize public health measures that have been communicated over the past 2 years have been successful in managing the situation. And the update from Katie about the 4th dose is another aspect that I wanted to touch base on. We are continuing to provide the vaccine in community clinics, supporting primary care and pharmacy, whether through vaccine distribution, cold chain, IPAC, infection control measures, and the public can get the 4th dose, and the 1st and 2nd, 3rd, which is all of them are recommended if people have not gotten the vaccine, in primary care, pharmacy, and public health clinics. And we'll continue to provide them so long that there's need for them in the community. So that's my update, Madam Chair. Open to questions as always.
Very good. Any questions for Dr. Era? None so far, Dr. Era. So you can, the next item, public health modernization, standing item.
There's no update from the ministry on this item, Madam Chair.
Okay, and 9.3, the opioid situation in Grey Bruce.
Madam Chair, with your permission, I'll turn it to Dr. Zayed's presentation.
Okay. So we can see that, Dr. Zayed, but we can't hear you.
Okay, sorry, I was muted. So good morning, everyone. As promised from the last meeting, I am bringing some data today to show the board members. And this data is related to 2 items, the opioid mortality data and opioid overdose. So we'll start with the opioid mortality data, and I will show you here in brief how this is really difficult to interpret sometimes, and how this is, first, the sources of the data comes from police records, emergency departments, and confirmed by the coroner. So sometimes, as I mentioned here, it's an issue requiring coroner confirmation, and it is really complex. Sometimes it's not only opioid overdose, there are other factors that can be combined with that. And sometimes it's more than one drug, or alcohol plus opioid, for example. So it takes time to get this confirmation. The data also is really, if you look at it from a first sight, if you want to compare it with other, for example, has a standard population or a reference to compare to Ontario or compare to Canadian data or other health units, we need to be really very careful about the data. And so we need to work through a process of standardization of data so that we can understand it in terms, especially for small population. We need to really be careful about how to read this data. So data analysis is really critical, especially with confounding factors. We need to read it also through social context and background. So all these are essential. So this slide shows, might be really small, but if you can try to increase. So it shows the data between 2019, 20, and part of 21 and 22. So this is data from the coroner and from the public health, PHO, Public Health Ontario, related to some suspected drug-related death and opioid toxicity death. So we can see the comparison between Ontario and Grey Bruce for 2019, 2020, and then there is 2021. So there is a steady increase overall. The comparison in counts, of course, it's higher in Ontario than in Grey Bruce. In 2020, this is for the suspected drug-related death, not specific to opioid. The second item is opioid toxicity death. So it is 16 for Grey Bruce in 2019, 26 in 2020, and 15 as per the interactive opioid dashboard of Public Health Ontario. Again, I will show you another slide where it shows that really the confirmation is still it is still an issue. Like you can see here, this is from the coroner's office, and it shows the data for 2019, 20, 21, and 22. You can see the asterisks on 2020, the last 3 years, and it shows that we can again go back to, the coroner still can go back to this parts. So all that one that has this yellow color is still needs more confirmation. It's probable. So, and the one that is green is confirmed. So that is the data for Ontario. And the suspect can be related to, still in that slide, suspect drug-related deaths include death where the preliminary investigation of coroner indicated drugs were found at the scene, or drugs and paraphernalia at the scene, or history of drug abuse, history of prescription of opioids, history of methadone or Suboxone, history of naloxone use, physical sign of drug use, positional asphyxia, unresponsive with snoring prior to death. So this is still all probable and is not confirmed. So it's really a tedious process, but again, this shows in general the aspect of confirmed opioid-related death. Next slide. This is if we delve more. As I mentioned, there is a process of standardization. So we know that by comparison that Grey Bruce is lower than Ontario, but there is there was an increase in the deaths. We go further to the by age group. So from 0 to 15, we don't have death in this age group. There is in Ontario, and above 64, there is in Ontario. We don't have in these two age groups. So we are focused on the 3 age group from 15 to 24, from 25 to 44, and from 45 to 64. And we do some sort of comparison here. And this comparison, in these 3 years, we do standardization of the data. So we take every percentage of population of this age group from Ontario and use that rate for mortality for Grey Bruce. and see how, if this population is that percentage, how much it would be the age related. So we have this interesting. This is not without standard. This data is without standardization, but I will go second with the standardization. But what we can conclude for this data is that the age 25 to 44 is the highest, and there is an increase in that age group in 2020. So here, this is what I am telling about the standardization. So when we compare it to Ontario, so the Ontario population percentage for the years, and then we can do that through age group by comparing it to Ontario. So you can see here the Ontario data versus Gray-Bruce mortality data. Again, it shows the increase in number in Gray-Bruce in 25, like the increase is corresponding the same increase in the province, but the increase in our focus here is mainly the 25 to 44. So with the standardization, if you see the right slide, it shows really that our main focus really needs to be that age group. For harm, of course, I'm talking now about harm reduction. So it is 15, and it in 2020, and in 20 and in that age group in 2019, it was around 1.7. So there is like 15 times increase. So that's with the standardization. Without standardization shows 10 times increase, but with this standardization and more focus on that, on the trend and the age group, we can have, we know that this is the age group that we need to focus on. This is mortality rate by gender. For Ontario compared to Gray-Bruce. Again, for the 3 years, it shows there is an increase in female in 2020 and 2019. The same as in male, but the increase in female started in 2019 more. And it is also the same picture of Ontario. And we can go through the standardization, but for the sake of time, I showed the standardization by age group that we do for age, but we can do the same standardization process to understand the data in depth for age group plus gender as well. So that's about the data for mortality. For opioid overdose, so the overdose, we relied on, we find really very resourceful source, which is the EMS calls. But again, I want to, when I delved into working with these calls, I find that we need a lot of work on that. It's a very good resource to start now, not only for harm reduction, but go further to a sort of prevention. So before death happens, so we need to know what is the situation about overdose. So there is, I find that we have codes, coded dispatch calls. It's called code 81 for drug alcohol overdose, and it is non-specific. And there is a code 81.1, which is related to opioid overdose suspected. With more work and exploration of that, we find that there is some misclassification of data between 81 and 81.1. So this is what we are really working now on, cleaning this data, and it is a tedious process where we will get the Excel sheet where the calls happen. So we go through the core scenarios and see if it is really opioid or alcohol or others. So, so that we can clean more the data of this code 81. But reliably now, we can focus on 81.1, which is opioid overdose suspected, until we get more cleaning of data. And there is other codes, which is 81.2 and 81.3 that explicitly coded as other substances. So we are really working on refining this call dispatch system for both EMS in gray and bruce. So I can show you the second slide, like how this is really difficult. We analyze this data. There is this code 81 is the blue one. The purple is 81.1 and then 81.3. So we are analyzing this data by months from 2018 to now. After more cleaning, we got this picture. Of course, there is an increase in the 81, which is the non-specific. There is also the 81.1, which is the probable opioid, and 81.2 and 81.3 are non-opioid. So this is by year. We started also to have an interactive dashboard mapping to know the number of calls from each municipality, so that again, all these are work related to knowing where to focus resources or allocate resources. This is by municipality and by gender. We can see here that Owen Sound have more opioid overdose calls compared to other municipalities. And there are some male calls in Owen Sound, Hanover, Seguin Shores, Meaford, and others. This is like more pronounced, but again, this data also needs more work to see its significance. Is it true that Owen Sound has more opioid overdose than others, or it is just because of certain factors people call more here? So we need to really dig deep into risk factors, either true risk factors or untrue, like factitious. And this is like a problem of access or a problem of awareness. So this is really a very important work that we need to do. But at least this data give us some guidance to start with. And then my last slide is about, as I mentioned before, that I'm a member of the COMO work group for opioid and the drug overdose. And this work group, as I mentioned, the last update on that they brainstorm on the priority, and one of them is developing provincial supporting the development of workforce, provincial workforce. The other thing is we highlight the priorities where local public health can be involved and take leadership. And the most important is harm reduction. But other things that harm reduction really, that is really important, is the sustainability of support of substance use prevention and mental health promotion initiatives, which focus on early childhood through adolescence. So if we really want to do like a real work from the grassroots, it's important to focus on early childhood through adolescence. Data, of course, as you see how data is important, like I can't see any program or planning, even for short term, let alone the long term, without really having this data analyzed in a very important, like in a very descriptive way and in robust way, either qualitative data or quantitative data, because as you see, it can be really interpreted in a very wrong way, or it can be inaccurate, and that affect planning. But I can't see any project without not being driven by data. Of course, the other priority that local public health is working on is anti-stigma and health equity, as we have through the foundational standard works equity impact assessment, and this is something that we are trying to expand over community collaboration or any community project to do the health equity impact assessment, efforts toward healthy public policy related to substance use, and this is an advocacy work and also collaborative work, including decriminalization or decriminalization alternatives and community leadership. And again, one of the things that happened, of course, after the Hanover outbreak, for example, that the report of the recommendation of the debrief summary of the outbreak, we recommended the outreach services. And I think we started that with our community partners. It is going well, and through data we can really work on monitoring that project. This is like just an example. And of course, these roles are aligned with substance use prevention and harm reduction guidelines and health equity guidelines under Ontario Public Health Standards. So it's also, we are privileged to have the Ontario Public Health Standards as guidance in public health. And that's it for me. Thank you.
Thank you, Dr. Zayed. Very good. Dr. Era.
Thank you, Madam Chair. Through you, thank you, Dr. Zayed, for this very informative presentation. I just want to echo a few points that Dr. Zayed mentioned. One of them is the limitation of the data, whether it's the coroner data or the local data, and limitation is manageable. For example, the limitation for the provincial data, the coroner data for 2021, we only have data up to July. We don't have the rest of the year. So any inference or conclusion will have to be with a grain of salt. There is definitely an opportunity to look at this data, and we are doing this. And I usually look at certain factors that will guide our action and our partners' action. One of them is location. If Dr. Zayed presented on a location of calls, and there is definitely the potential for artifact in this. Is it because Owen Sound has more access to services, so people reach out versus the disadvantaged people in geographic locations who cannot really call? So the coroner data would eliminate part of that potential confusion. It will give a more robust picture. So we look at the geography in Grey Bruce. Where is the place that we need to focus most? And we will provide services all over, but we need to, again, address the issue that's affecting the population most. Age group, and there is difference between the province and Grey Bruce. Our age group that's most affected, people between 24 and 45. And this is consistent with the 2018 data that was at this point, very complete and has been complete for a while, where there is a lot of effort for outreach for people without home who have housing challenge. And the data very clearly said that's not where the problem is. Almost all the deaths in 2018 were people who are employed, living in their own residence, and between the age, I believe it was around 35 to 55. So going with outreach and augmenting it is definitely helpful, but it's not helpful for the majority of people who are dying. Other variable I would look at, as I mentioned, employment status. We don't have this data yet, or when the data from the coroner office is complete, it will provide that. Time, and time could be related year to year, comparing years and what's happening. Is it increasing, decreasing? And it could be within a year, looking at the months where there's the most issues, whether it's around New Year's or in the summer. There are certain weekends that would have more impact, and we need to be prepared for it based on the previous data. Worth mentioning, in the map Dr. Zayed presented, and even in the map that Katie presented, indigenous community remains white area on the map, because we don't collect data, we don't analyze the data without the permission from the chief and council. Nevertheless, the services are there, but for this presentation, we always white it out. And Madam Chair, those are my comments, and I want to take it next step there to, I would ask the board, with your permission, to approve writing a letter to the Minister of Health and the Associate Minister for Mental Health and Addiction. The Associate Minister has been involved heavily in the subject at hand, and has shown that they are very supportive of new initiatives and innovation. And that letter, if permitted, would look at two objectives: to ensure that we highlight that Grey Bruce has started utilizing new initiatives to address mental health and the opioid crisis. And 2 points to be addressed as well is to keep the Office of the Minister and the Associate Minister posted, and to ensure connection between local public health initiatives that we'll be developing, and we have been developing, and the rest of the province or the provincial level, to ensure knowledge translation is up to date. And we, to achieve these last 2 points, keeping that office posted and to ensure knowledge translation, I would ask the board to strongly request representation from our board on a task force that is provincial. And I should apologize, I misunderstood last meeting Helen Claire's request or question about the task force. She was referencing the provincial task force to be struck or to be put together, that committee. And I was referencing the local Grey County task force, and I was saying, you know, that is local and their operation in it. So again, if the board would support writing a letter highlighting what we're doing and the need to connect ourselves with the provincial level, and strongly recommend representation from our board on the provincial task force, I do believe that will put a positive dent in the crisis, not just locally, but provincially.
Okay, good. Comments? Questions? Helen Claire?
Thank you, Madam Chair, through you, and thank you, Dr. Ara, for those comments, and thank you, Dr. Zayed, for that incredible presentation with so much data. So I have a question, first of all, through you, Madam Chair, to Dr. Zayed. When there is a death in which there's multiple toxicities, so could be prescription drugs, could be alcohol, it could also be fentanyl and even cocaine or meth or anything. And the cause of death, it's accidental, but the manner, or rather the manner is accidental, but the cause can't be, it could be a number of any combinations. Is it captured as an opioid death, or is it unknown? I know that there is a significant time delay in getting a coroner's report for when an individual has passed as a result of drug involvement, but I'm just wondering how that's captured in the data, if it's possible even for Dr. Zayed to answer that.
Through you, Madam Chair. Thank you, Helen Claire, for the question. It's really a good question. Actually, the coroner captured that as probable opioid death. Not confirmed, but again, this one is the one that I mentioned in yellow, that they can come back to it when they have more results and see if there is higher concentration of a substance rather than other, and the lethal dose of this substance, and whether there is an underpinning, like one to be confirmed as opioid, for example, versus others. But it is captured in the data of the coroner. as probable opioid death.
Thank you. And if I may, Madam Chair, to Dr. Ara's comments, this community, Grey Bruce, is doing so much all at once on multiple levels. For example, the Grey task force that we heard about. I was really heartened to see the Associate Minister of Health, Minister Tibolo, who's responsible for mental health and addictions, to be in this community, to be announcing the pilot project that we have here with the additional beds in Owen Sound. And I'm heartened also by the announcement of the province of the Addiction Recovery Fund. And it would seem to me that Minister Tibolo seems to be really committed, really seized by this issue. And this area could be a microcosm that the province uses if a letter could be sent that suggests such a thing. We could really use those funds in this area and really, really use all the resources we have, all the commitments to these task forces at the micro level to really, really drill down to what's going on here, because the micro will show the macro. And so I completely support Dr. Ara's suggestion. And I once again, like in the last meeting, volunteer to be involved in this in any manner. I am personally seized by this issue and want to help in any manner. Thank you, Madam Chair.
Thank you, Helen Claire. Any other comments or questions? Dr. Zayed.
Through you, Madam Chair, I echo what Helen Claire mentioned, and this and what Dr. Ara suggested is really aligned with the COMO working group that supports and will send also a letter to encourage or recommend or highly recommend this task force at a provincial level.
Okay, very good. So, Brian O'Leary.
Thanks, Madam Chair. This is just my curiosity, but one of the slides, Dr. Zayed, that you had up there showed Grey Bruce higher than the Ontario average, but you had to go back to 2012 to see that. And I'm just wondering, do we have data from, like, was there a period of time where Grey Bruce was raging out of control? Or do you have that kind of data? Or was that just a bump in the road in 2012?
This data. This is the data of mortality. That's what I'm talking about. That this data is not standardized, so we can't rely on data like that without having the standardization that is done in other slide. Can you show the other slide where there is standardization, like the two, not this one, going back, no. 1 second. Slide number 8. So this data is standardized. As I mentioned, this standardization, it wasn't done for 2012, but we can go back to the data of 2012 and do the standardization. And with the standardization, we can really confirm if it was an actual increase or not.
Okay.
But this is the data that are standardized from 2018.
Okay, thanks.
Okay.
And I just want to mention also that we have the data of the calls for with employment. So we are working on that, but our first step really is make sure that EMS collect the data in a standard way. So it's really like tedious process for now, but it will really help us a lot on getting the true picture of the situation for overdose and where we can put our resources.
Okay, Brian?
Yep, thank you.
Okay. Any other questions or comments? All right, I'll ask for a mover and seconder to receive the MOH update as presented, and that includes the recommendation to send a letter to the Minister of Health and the Associate Minister, along with a request for a Grey Bruce rep on the provincial task force. So I have Brian O'Leary, you're moving, and Brian Millen seconding. All in favor? That is carried. Very good. Good presentation, Dr. Zayed. Moving on, normally at this point, we would have a finance report following the MOH update. And I just want to share that as the budget for 2022 was just completed, it's been recommended by Kim Rutherford, the finance manager, to present a quarterly report at our next meeting. So you'll see January, February, and March. And she has shared that the budget was presented last month and there was not much change at all on that. So we'll move on to item 10, which is other, and 10.1 is the Alpha Elections Primer. So they've issued correspondence stating that they want to remind audiences that the principal consequence of the pandemic response efforts over the past 2 years has been a near total redeployment of resources. We're fortunate, our health unit, Grey Bruce Health Unit, has been able to continue most programs, although some were streamlined. And resuming these activities are going to entail a 2-year backlog, which we all know. And COVID-19 will become a routine for the health unit for the foreseeable future. And they're asking that public health be put at the forefront, hoping that all candidates will consider these objectives during their election platforms. And I just want to remind everyone that we should all be considering the public health when we're making our decisions at whatever table we're sitting at, because it affects all of us. So that's just for information. And then the final, unless someone else has any other business, we have one other motion, and that's to adjourn at 11:31. So I have Brian Millen and Helen Clare. I know it's a record. All in favor? That's carried. Thanks very much. That was a good meeting. So
Have a good weekend, everyone.
Thank you all.
Thanks, everyone.
Take care.
Bye for now.
Enjoy your day.